Generally, what is the standard treating cancer-associated thrombosis?
Well, cancer-associated thrombosis is actually a different beast to thrombosis in non-cancer patients.
Okay.
We know that these patients have a higher risk of getting recurrent blood clots, and data has also shown that patients, when they were originally treated with oral medicines such as warfarin, had an increased risk of bleeding.
Mm-hmm.
So rather than using oral agents to treat, we actually use a group of drugs called low molecular weight heparins.
Yep.
They're an injectable anticoagulant. And we found from studies that the rate of blood clot recurrence is halved. There are other benefits as well. These medicines do not interact with chemotherapy, so you can carry on having your treatment. It's not going to interfere with your cancer treatment, so that's very important. For people where absorption of drugs are a concern, or you're feeling too sick to hold your medicines down, the fact that it's getting injected, you know it's working. But the bottom line is that these drugs have been shown to work better than the current standard we give to non-cancer patients. Now, I recognise that no one would say, I'd love to have an injection.
No.
I know for some people they find it quite daunting. But I also know that people would not ask to have the second best chemotherapy to treat their cancer.
Of course.
So why would we want to give them the second best anticoagulant to treat an anticipated and recognised complication of their cancer?
Okay.
Our patients deserve the best treatment. And people get very good at learning to inject, learning to adapt to this and making a routine.
Now, with these injections, I myself did injections for 2 years
Yeah.
straight. Are they being shown as well what areas to inject for themselves? Are they being taught to do this for themselves so they can go home and do it? And the different areas, you know, your thighs, your stomach?
Well, I think the first thing I'd say is that the studies that have been done in cancer-associated thrombosis have gone up to and as far as 6 months.
Okay.
So that's the official line, is we treat people for 6 months. But we know if people have an ongoing risk of blood clots, so for example the cancer is still active,
Yep.
or they're having ongoing chemotherapy, it would make sense to carry on with the injections. Now, the initial patient guidelines or patient leaflets would say just inject under the navel here.
Yep.
But once you've done that for a few weeks, you've just got a bruised navel.
That's
and you
rock
ain't got
hard.
any space. Absolutely.
Absolutely.
Also, this area will then heal with scar tissue, which you cannot inject into unless you want it to hurt some more pain. So what I recommend to patients is anywhere you can pinch fat is fair game.
Okay.
And well, with my belly, I reckon I could go for a couple of years without difficulty. And I say to patients, so long as you can pinch the fat and inject, go for it. Rotate sites. If you want to go round, I don't know, you call it muffin top in Canada, or we call it love handles. Go all the way round.
It's a love handle for
It's
you.
a love handle for me. I've got a lot of love there. And what we would say is just rotate.
Fantastic.
But also we've got to see that patients are individuals and quality of life is essential here.
Of course.
And so sometimes if they are no longer tolerating the injection, we may then wish to consider another agent. So I think it comes down to individualised care at that point. And sometimes that requires an expert in coagulation or in cancer-associated thrombosis. But for the first 6 months, with very few exceptions, I'd be saying patients should have a daily injection of low molecular weight heparin.